Hello everyone, welcome back to Tutor Series. My name is Shujauddin, and in today's lecture we're going to talk about Alzheimer's disease. So Alzheimer's disease is basically a common cause of dementia in old age adults. So let's see what happens in Alzheimer's disease. We're going to discuss everything in this lecture, starting from the pathophysiology, the risk factors, the clinical features, and the diagnosis and management of Alzheimer's disease. So let's start with the pathophysiology. So what happens in Alzheimer's disease is that you have a normal protein which is called your amyloid precursor protein, short for APP. So amyloid precursor protein, now this protein is encoded on chromosome number 21. So chromosome number 21 encodes this protein. Now this protein is normally present in every person, and they all make amyloid precursor proteins. Now this protein has two fates. It either undergoes cleavage through the alpha pathway, or it either undergoes cleavage through the beta pathway. So if it undergoes cleavage through the alpha pathway, that is normal and there's nothing to worry about, right? Like, this is completely normal. But if it undergoes cleavage through the beta pathway, now that is when you need to worry about, because the beta pathway is abnormal, it's not normal. So I'm gonna write this down. This one is normal. This happens in everyone, while this is abnormal and this does not happen. And if it's happening, so you'll be at an increased risk of developing Alzheimer's disease, right? So now when you have the beta pathway happening, you end up making beta amyloid. What do you end up making? You end up making beta amyloid. Now this beta amyloid, it starts accumulating inside your brain. Now how does it accumulate and what does accumulate inside your brain? We're going to talk about this right now. So due to beta cleavage, you end up having beta amyloid, right? And this beta amyloid is now going to start accumulating. Where is it going to accumulate? Inside the person's brain. Now, how will it accumulate? It's going to accumulate extracellularly. So what happens to beta amyloid is that it starts accumulating extracellularly inside your brain, and it gives rise to what? It gives rise to neuritic plaques. Yep. So what are neuritic plaques? It's basically extracellular deposition of beta amyloid. Now apart from neuritic plaques, you also have another thing that is present in Alzheimer's disease, and it's very specific to Alzheimer's disease, that is hyperphosphorylated tau protein aggregates. So just like beta amyloid, you also have high levels of hyperphosphorylated tau protein. So hyperphosphorylated tau, it starts accumulating. Now this is intracellular, right? So hyperphosphorylated tau is basically intracellular, and when it starts accumulating inside the person's brain, you end up having what? Neurofibrillary tangles. What are hyperphosphorylated tau proteins called? They're called neurofibrillary tangles. Now, so you have two things, that is neuritic plaques and neurofibrillary tangles. These are the two things that are present in Alzheimer's disease and that accumulate inside the patient's brain, right? So this is basically a brief pathophysiology on amyloid precursor proteins pathway. If it's alpha cleavage, normal, beta cleavage, abnormal, and you end up having neuritic plaques and neurofibrillary tangles inside the patient's brain, right? Now apart from this, there are a few risk factors that can also cause Alzheimer's disease. Now I'll discuss the first risk factor, which is age. Age is the strongest risk factor for Alzheimer's disease, right? As you age, your risk of developing Alzheimer's increases and multiplies. So age is a very strong risk factor. Apart from age, a positive family history is also a predisposing factor for Alzheimer's disease. Positive family history. Apart from positive family history, a patient of Down syndrome will also have an increased risk of developing Alzheimer's disease. Now, why? Because in Down syndrome, you have an extra copy of chromosome number 21, right? So, chromosome number 21. And the amyloid precursor protein is also encoded by chromosome number 21. So an extra copy would mean extra amounts of amyloid precursor protein, and extra amounts of amyloid precursor protein is definitely going to mean increased risk of that protein undergoing the beta cleavage, right? You just have two pathways. So if you have increased protein, it can either undergo the alpha pathway or the beta pathway. So if it undergoes beta pathway, what are you going to get? Alzheimer's disease, right? So Down syndrome increases the amyloid precursor protein's quantity, and it also increases the risk of undergoing beta cleavage and causing neuritic plaques and neurofibrillary tangles inside the patient's brain, causing dementia, which is Alzheimer's disease, right? So Down syndrome is also a risk factor. Now, apart from this, you can also have early age Alzheimer's disease. Now, early age Alzheimer's disease is caused by mutation in either presenilin 1 or presenilin 2. These are two genes. I'm going to mention this here. So, mutation in presenilin 1. These are basically coded on, these are genes and they are coded on chromosome, I'll mention this here. So presenilin 1, which is coded on chromosome number 19, or presenilin 2, which is coded on chromosome number 14. So if you have a mutation in either of these, you can end up having a early age Alzheimer's disease. Now, one thing that also increases your risk of developing Alzheimer's disease is the presence of the epsilon 4 gene, that epsilon 4 allele of the apolipoprotein E gene, that is short for ApoE. I'm going to mention this here. If you have the ApoE gene, which is, by the way, coded on chromosome number 1, right? So if you have ApoE gene, it has two alleles, that is epsilon 4 and epsilon 2. Epsilon 4 allele increases your risk for Alzheimer's, while epsilon 2, it decreases your risk of developing Alzheimer's. So if you have epsilon 4 of the epsilon 4 allele of apolipoprotein gene, you can end up having Alzheimer's disease. But if you have the epsilon 2 gene, you'll have a reduced risk of developing Alzheimer's disease. So this was basically a brief pathophysiology that happens in Alzheimer's disease. Now, as you know that there are different neurotransmitters that play a role, and if they are imbalanced, if their amounts are high or low, you can end up having different diseases, right? So if I were to say reduced amounts of dopamine, the first thing that's going to come to your mind is Parkinson's, right? Because in Parkinson disease, you have reduced amounts of dopamine. So just like that, in Alzheimer's disease, you also have a reduced amount of neurotransmitter, but it's not dopamine, it's basically acetylcholine. So low amounts of acetylcholine are present in Alzheimer's disease. Now, where is acetylcholine located, and how does its deficiency happen? So acetylcholine is majorly present in cases of Alzheimer's disease. It is present in the basal nucleus of Maynard. Now, reduced levels of acetylcholine in the basal nucleus of Maynard can cause Alzheimer's disease. And why do you have reduced levels of acetylcholine? Is because of deficiency of this enzyme that is called acetyltransferase. Deficiency of acetyltransferase. So reduced amounts of acetylcholine is present in Alzheimer's disease. So if anyone asks you which neurotransmitter is in reduced amounts in Alzheimer's disease, you're going to say acetylcholine. Now coming on to the clinical features, that what would you see in a patient of Alzheimer's disease, right? So like I said, the first thing that I mentioned was dementia, and I've also written this little sentence here, where am I? So basically in patients of Alzheimer's disease, you tend to forget everything. Like you tend to forget birthdays, you tend to forget people, you tend to forget where you are, what you have to do, right? So you basically have dementia. Now dementia is memory loss, right? So you will have dementia, but it's first going to be short-term memory loss, and then it's going to progress to long-term memory loss. So it's going to start with short-term and progress to long-term memory loss. And this is going to be progressive in nature, right? This is going to be progressive. The dementia won't be rapid, it won't be acute, it's going to be progressive. The patient is definitely going to come to you with a history of a year and a half, more than 6 months at least, because acute dementia points you towards different pathologies, but not Alzheimer's disease. Yes, what can happen is, normally Alzheimer's disease happens in the age of 60, 70, 80, but you can have a patient of Alzheimer's disease at the age of 40 or 50. Why? Like I mentioned, that if you have mutations in presenilin 1 or 2, you can end up having early age Alzheimer's disease, or a patient of Down syndrome can also have early age Alzheimer's disease, but the memory loss will always be progressive. That is more than 6 months, a year, more than a year, not 2 or 3 weeks, not 2 or 3 months, not 4 months, because that dementia, if it's acute in nature, should trigger you to either Creutzfeldt-Jakob disease, because in that you have acute dementia. So you'll have dementia starting from short-term memory loss, which will progress to long-term memory loss. Apart from this, you will have other features as well. You might have aphasia, that is, the patient might not understand what you're saying, they might not speak as well. Apart from aphasia, they will also have anosognosia. Now this condition is basically where the patient is going to say that I'm completely fine, nothing's wrong with me, and the patient is going to come to you with an attendant. Now in Alzheimer's disease, you will never have a patient coming into your clinic, walking by themselves and coming and saying, hey doctor, I tend to forget a lot of things now. No, this is not how it's going to happen in Alzheimer's disease. In Alzheimer's disease, you'll always have a attendant dragging the patient inside your clinic and telling you, hey doctor, I've noticed that this person is forgetting everything. They forgot my birthday, they forget where they are, they forget their keys, they forget their things here and there, and it's getting very difficult to handle them. So the patient is and when you're going to ask the patient is going to say, I'm completely fine, there's nothing wrong with me. So apart from aphasia and this, you will also have agnosia, where the patient might just stop recognizing people. They might not be able to do motor tasks, that is apraxia. So apraxia is loss of motor tasks, reduced motor tasks. Apart from that, like I said, agnosia, where the patient might not recognize people. So the patient is usually going to just sit in their room, they'll probably be bedridden, they won't be able to do their daily tasks, that is speak, get involved in activities. They're just gonna stay in bed all day, bedridden, unable to do any skillful activities, with memory loss. All of these things are going to be present in a patient of Alzheimer's disease. But one thing to note, you will never have any focal neurologic defect in Alzheimer's disease. Yes, apart from Alzheimer's, if a patient has a stroke, stroke as well, then they can have all these features along with focal neurologic defects. But a patient won't come to you with just Alzheimer's disease and saying that I have arm weakness, leg weakness. No, that is not what happens in Alzheimer's disease. In just a specific Alzheimer's disease, this is what you see in a patient of Alzheimer's. Now, when a patient comes to you with Alzheimer's disease, and if you were to look at their brain, what changes would you see inside their brain? So inside their brain, you would find neuritic plaques and neurofibrillary tangles. If you were to see under the histopathology slides. But if grossly, if you were to see a patient's brain who has Alzheimer's disease, what would you see? You would see cortical atrophy. That is atrophy of the brain. So the patient has a smaller brain compared to a normal individual without Alzheimer's disease. So their brain shrinks in size. You have cortical atrophy. Now what usually happens is that if I were to draw a brain here, so sorry. I'm really bad at drawing, but if this were to be the patient's brain, so this particular thing is going to be your gyrus, and in between the two gyrus you have your sulcus, right? So this is your gyrus, and in between the gyrus, this space is called your sulcus. So what happens is that when you have atrophy of the brain, your gyrus shrinks and the sulcus widens. So what will happen is that this will be your gyrus and this will be your gyrus, and the sulcus has widened, right? Normally it should be completely joined like this, but no, the gyri are going to shrink in size and the sulcus is going to increase in size. So you will have narrowing of your gyrus and widening of your sulcus, along with atrophy of the brain in general. Now over here, what happens is that due to atrophy and due to loss of your brain matter because of shrinking, the ventricles tend to increase in size. Now the ventricles tend to increase in size because you have atrophy of the brain. If you didn't have atrophy of the brain, your ventricles wouldn't increase in size. So basically this is a compensatory mechanism going on, that with atrophy of the brain you have compensatory enlargement of your ventricles. So you will also see this if you were to examine a patient's brain. What would you see? Enlarged ventricles. Now due to the enlargement of ventricles because of atrophy of the brain, there is a special term that is used for such enlargements, which is called hydrocephalus ex vacuo. Obviously if you have increased area of the ventricles, you will have increased volume of CSF, right? So what would you have? You will definitely have hydrocephalus, but you just don't call it hydrocephalus because this hydrocephalus is secondary to atrophy of your brain. You call it hydrocephalus ex vacuo. I'm going to mention this here. Hydrocephalus ex vacuo. Right, so enlargement of your ventricles, reduced size of the brain, reduced gyri, widening of your sulci. This is basically what happens inside a patient's brain with Alzheimer's disease. So let's come on to the diagnosis, that how, if a patient comes to your clinic, how would you reach the diagnosis of Alzheimer's disease, right? So the way you diagnose this patient is that you need to understand the problem here. The problem is that he has declined cognitive function, right? I mean, due to dementia, his cognitive function is going to decline. So you need to test the patient's cognitive function. So test their cognitive function. Now, how can you test a patient's cognitive function? You have multiple tests through which you can do that. One of them is the mini mental state examination, which is short for MMSE. SE. So it is basically like, it has a scoring system in which, like, you tend to score a patient, and see like what score is coming. So in a patient of Alzheimer's disease, obviously your score can be reduced, and you can also have a, like, approximately normal score as well, but that is usually rare. When you do a mini mental state examination on a patient of Alzheimer's disease, you will get a reduced score. Now there is a cutoff, and in that cutoff you basically decide the management of that particular patient. So the management options are basically like, you give them two things. The first thing is that you give them a cholinesterase inhibitor. Now giving them a cholinesterase inhibitor makes sense, because what does cholinesterase do? It breaks down acetylcholine. So if you were to inhibit the enzyme that breaks down acetylcholine, what would you end up getting? You would then end up getting a high amount of acetylcholine, or if not high amount, at least your acetylcholine won't be that much reduced in a patient of Alzheimer's disease, right? So basically you're trying to tackle the patient's disease. So giving them a cholinesterase inhibitor is going to, like, at least try to maintain the levels of acetylcholine in a patient of Alzheimer's disease. Now the second drug that you, the class of drug that you give them is the NMDA. Now NMDA glutamate antagonist. Now when do you give cholinesterase inhibitors and when do you give them NMDA glutamate antagonists? That's what we're going to see here. So if you were to get a mini mental state score of 19 or more than 19, so a score of greater than and equal to 19, you will give the patient cholinesterase inhibitors. Now cholinesterase inhibitors are basically donepezil, galantamine, rivastigmine, these are cholinesterase inhibitors, and that is what you give to a patient with a mini mental state score of 19 or more than 19. But let's say if you were to have a reduced score, that is less than or equal to 18, that is when you would give the patient glutamate antagonist. And glutamate antagonists are basically memantine. That is the name of the drug. Memantine is what you give to that patient. So basically this tells you a idea that if a patient has a score of 19 or more than 19, this would mean mild Alzheimer's disease, right? A reduced score that is 18 or less than that would tell you a severe Alzheimer's disease. So if anyone asks you that what would be your management in a patient of mild or moderate Alzheimer's disease, what would you say? You give them cholinesterase inhibitors if you were to give them a pharmacotherapy drug, because you can also manage the patient on improving their lifestyle. What you can do is that in a patient of Alzheimer's disease, you advise them to maintain a normal sleep schedule. You try to counsel them for a normal sleep schedule, have a healthy lifestyle and everything. But apart from that, if you were to go on to pharmacotherapy, so then you would have to see if it's mild, moderate or severe, because if it's a mild moderate Alzheimer's disease, you are going to go for cholinesterase inhibitors, which are donepezil, galantamine, rivastigmine, right? But you don't have to give all three of them. You can give either of these three, but just one drug. Or if there were score were to decrease, that is reduced less than 18 or 18, then you would go for NMDA glutamate antagonist, which is your memantine, which is given for severe Alzheimer's disease. So just to briefly talk about memantine, what memantine does is that it prevents your cognitive decline in a patient of Alzheimer's disease by inhibiting abnormal brain activity. So it is going to inhibit abnormal brain activity. and it also tries to keep normal levels of acetylcholine as well, maintains your acetylcholine levels as well in a patient of Alzheimer's disease. So this is basically your management in a patient of Alzheimer's disease. So I hope that you guys were able to understand the whole concept behind Alzheimer's disease, that is starting from the pathophysiology, the risk factors, what clinical features would you see in a patient of Alzheimer's disease, and the diagnosis, that is through testing their cognitive function, that is a mini mental state examination on which you can score the patient and see which drug to give, if it's mild or mild, moderate or severe, and that is how you go about it. And if you were to go for lifestyle improvements, you advise the patient to maintain a normal sleep schedule. Just one thing that you need to understand is that in Alzheimer's disease you will always have progressive dementia. If the question gives you a acute history, do not opt for Alzheimer's disease. So I hope that you were to you were able to grasp the whole concept behind Alzheimer's disease. Thank you so much for watching. Allah Hafiz.